Good afternoon. My name is Daniel de Bakker from the Department of Intensive Care, Schreck Hospitals, Brussels, Belgium. I will discuss the involvement of the heart in the COVID-19 infection. There are really several potential effects of the coronavirus on the cardiovascular system. And one of these is really due to the inflammation of the vascular system and the increase of sympathetic stimulation, the development of the risk of a myocardial infarction. Another aspect that can be observed is also the development of the heart failure, mostly due to involvement of the heart, such as myocarditis in these conditions, and also myocardial depression due to the presence of pro-inflammatory cytokines. Finally, there is also a risk of arrhythmias due to several aspects, including the myocardial involvement of the heart, but also the pro-inflammatory effects of the cytokines, and also the increase in sympathetic stimulation. What is the evidence of the involvement of the heart in COVID-19? Well, in this series of close to 400 patients, 82 of these patients had cardiac injury defined as an increased troponin level. Interestingly, patients without elevated troponin levels have a very low mortality, while patients with an increase in troponin levels have a more severe form and more risk of death in these conditions. When we look at the different factors associated with risk of death in these patients, we can see that it was mostly the RDS and the involvement of the heart that were associated with a poor outcome in these patients. What could be included in the definition of cardiac injury? Well, we have several traumatic events, and of course, acute myocardial infarction is one of these, but we should not forget the pulmonary embolism, which is the second very important traumatic event. Myocarditis is, of course, very important concern. Pericarditis can be observed. Myocardial depression is a very important aspect. Acute cor pulmonale, as its classical RDS, can also, of course, be observed. And finally, coronary aneurysm in Kawasaki-like disease can also be considered. Regarding arrhythmias, we do not have a lot of description in the literature up to now. In this systematic review of 5 studies, we can see that indeed there was some arrhythmias occurring in 7 to 15% of the patients here, and was of course associated with a significant mortality in many of these patients. Also, development of myocardial infarction can be observed. Here it's a very small series of patients here. It is interesting to realize that ST elevation is not synonym of the acute myocardial infarction, because among the patients presenting ST elevation, only half of these patients had true myocardial infarction. When we look at histologic findings, we can see indeed a variety of alterations. First, we can detect easily viral particles directly into the myocardium. This doesn't mean that there is any other thing, because indeed there is no very significant signs of inflammation there, because you can see that even though we had a number of viral copies in the myocardium, there was no sign of activation of the inflammatory cascade in the myocardium in these hearts. So there were no signs of local inflammation, even though the virus was present in these conditions. Also, there were some macrophagic and lymphocytic infiltrates, but the myocytes were normal. So there was not really myocarditis at this stage in these patients here. On the other hand, in some other cases, there was some true myocarditis with cardiac myocytes presenting focal degeneration and necrosis. When we look at biologic and imaging findings, this is a little bit different, because we have much more signs of myocardial involvement in these conditions. Just by looking at the echo, we can see that in this patient on admission, there was a decrease in left ventricular function. And when we looked at the NMR of this patient, we see also there was some signs of edema in the wall of the myocardium of this young patient, by the way. Also, there can be some other signs, like in these patients here, with the signs of focal myocardial necrosis occurring in this patient with myocarditis associated with COVID. This was reviewed in a moderate series here of patients with COVID, presenting most of these patients high elevated troponin levels. And these patients later on presented still some alterations as the cardiac NMR. And indeed, some of these patients presented some alterations here that were not related to ischemic events, and so much more myocardial edema, and some others presented some ischemic lesions, as you can see here, in these conditions. And some other patients presented a combination of ischemia on one hand and non-ischemic lesions on the other hand. So distinguishing between sepsis-induced myocardial dysfunction and myocarditis is not easy. Just looking at these cases here represented fulminant myocarditis, it looks very nicely as just sepsis-induced myocardial depression. And there is no major difference here, elevated troponin normalizing and normalization of the function after a few days here. So distinguishing between the two is not easy. Probably troponin rises more in myocarditis than in just functional impairment. Also, there is a similar response to anti-inflammatory agents, and there is often a rapidly resolving aspect. So NMR can be helpful to really identify this aspect. And again, looking at myocardial edema and perhaps also pericardial effusion is also very important. Here you can see that the association of myocardial edema is also associated with a lymphocyte infiltrate at the biopsy, at the myocardial biopsy, and with the presence of pericardial effusion. So all these signs together may orient a little bit more throughout myocarditis in these patients. It's important to realize that cardiac involvement is occurring in 80% of the patients here in this series. And this is really something to realize, that it can occur even at a delayed fashion. It can occur even 3 to 4 months after the diagnosis. So it's not only an early finding, can also last for some significant period of time. Another aspect is that pericarditis is quite frequent. And first, it's we can look at the inflammatory aspect of pericardium here with these roughly lines, and also the presence, of course, of a liquid often presented in some of these patients. You can see again here the liquid in the pericardium very nicely is seen here. Also detected, of course, by NMR in these conditions. To end up, we also have to consider the fact that we can have Kawasaki-like disease in these patients, and that this is manifested mostly by some clinical symptoms like the strawberry tongue, the conjunctivitis, the rash, and of course, erythema of the palms, and that this has been markedly described in the COVID-19 pandemics, and this seems to be something related to the immune response to the COVID-19. And this can also occur in adults. Importantly, this can respond to tocilizumab and may require immunoglobulin for the full therapy of these patients. And some of these patients may develop the coronary artery aneurysm that need, of course, in these conditions, the full therapy, immunoglobulin, and sometimes steroids to resolve. So the heart is involved in different forms of the COVID-19 infection. While the virus spreading into the myocardium is quite usual and asymptomatic, cardiac involvement may also result from direct focal inflammation, systemic inflammation, and delayed immunologic reactions. In addition, of course, thrombotic events, pulmonary embolism, and acute myocardial infarction can also affect the heart. And with this, I thank you very much for your attention.